among these all antiviral, the important for practical purpose as well as for the examination, most important is the antiretroviral therapy. From the name we can understand it is the therapy, pharmacotherapy or drug therapy against HIV infection. So HIV is a antiretroviral and it is a retroviral virus having a DNA or RNA. It is a RNA virus. So the regime we followed, another term is that highly antiretroviral therapy. Sometimes came as a short note HAART. As a short note, just giving HAART. There is no explanation of that. So you have to remember that HAART, the full form is Highly Active Antiretroviral Therapy. If short note comes, you have to write down the principles, the drugs used and how to use, when to start, when to, is there any chance to stop this, or what are the combination of the drug, how many drugs to be given. Supposedly in tuberculosis, how many drugs to be given? In tuberculosis, now at a time, how many drugs to be given? At least 4. At least 4. And what is the advantage of this? Why we are giving 4 drugs? To prevent drug resistance. Primarily to prevent drug resistance, to counteract different types of subtypes of tuberculosis. Similarly, in retroviral therapy, we have to give multiple drugs to counteract. Before going to the proper therapy, principles of therapy, we have to remember the what are the drugs, classification of the antiretroviral drugs. So first where how these HIV infection infected, they infect which type of blood cell? T lymphocyte. T lymphocyte is infected primarily by this HIV infection. So they first attached with CD4 cell. There is CD8, CD4 and T helper cell. Primarily they bind with the CD4. After binding with the CD4, they release their, by the uncoating they release their RNA. Now there is a difficulty. There is a RNA and human has a DNA. So there is another step, specific step for the HIV, that is the reverse transcription. That means primary transcription means DNA to RNA, reverse means RNA to DNA. For this, reverse transcriptase enzyme is there. So from the viral RNA, it converts a double stranded DNA, and that DNA binds with the human DNA. After that, replication of that human DNA also replicate the already double stranded viral material. Then they release that, and after that the assemble of this virus and release of this virus. Clear up to this? So why it is important? To remember an understanding of the mechanism of action of different antiviral drugs. So there are 2 inhibitors, fusion inhibitors and CCR5. You have to remember all these names because primarily it comes alternate year as a long question, part of long question. So what are the different or classify antiretroviral drugs? First hoche fusion inhibitor, enfuratide. Fusion inhibitor, enfuratide, they inhibit kake? HIV to bind with the CD cell, the receptor CCR5. Then CCR5 co-receptor antagonist. It is a co-receptor. CCR5 is a co-receptor of CD4. That is inhibited by Maraviroc. So two classification of this drug one is enfuratide, that is fusion inhibitor, and CCR5 co-receptor antagonist maraviroc for MCQ purpose also and for classification of antiretroviral therapy. These two drugs primarily inhibit entry of this virus. So entry is inhibited by two drugs. One is fusion inhibitor enfuratide fusion inhibitor, maraviroc, that is CCR5 co-receptor antagonist. CCR5 co-receptor antagonist. They prevent HIV virus to attach and goes inside the human CD cells. After that, there are nucleotide inhibitors. There are three types. You have to remember this. Nucleoside reverse transcriptase inhibitor. The name says that they inhibit reverse transcriptase. Reverse transcriptase is that enzyme which reverse transcriptase means from the RNA portion of the HIV virus, they make a double stranded DNA before integration. So reverse transcriptase inhibitor, there are three types: nucleoside side reverse transcriptase inhibitor, nucleotide reverse transcriptase inhibitor, and non-nucleoside reverse transcriptase inhibitor. Clear? Reverse transcriptase inhibitor, there are three types. One is nucleoside reverse transcriptase inhibitor, nucleotide reverse transcriptase inhibitor, and non-nucleoside reverse transcriptase inhibitor. Clear? So first, entry inhibition by two types of drug. One is fusion inhibitors and another one is CCR5 co-receptor inhibitor, maraviroc. Enfuratide is the fusion inhibitor. Then if some of this virus goes inside the cell, there are drugs to prevent reverse transcriptase enzyme. Reverse transcriptase enzyme, they inhibit the reverse transcriptase enzyme helps RNA viral portion to make a double stranded. So that enzyme is inhibited by three types of drug. One is nucleoside reverse transcriptase inhibitor, nucleotide reverse transcriptase inhibitor, and non-nucleoside reverse transcriptase inhibitor. Clear? Name for nucleoside: zidovudine, statuvudine, lamivudine, abacavir, diadenosine. You have to remember this. And among these, you have to remember one name, abacavir. Most of these are ending with din, D-I-N-E. Abacavir, they end with the VIR. Whereas tenofovir is the nucleotide reverse transcriptase inhibitor. Non-nucleoside reverse transcriptase inhibitor is nevirapine, efavirenz. At least remember these two. Nevirapine, efavirenz is non-nucleoside reverse transcriptase inhibitor. So after that, what happens if there is a double stranded viral material already produced? Then they bind with the DNA portion of the host DNA. That binding is integrase inhibitor. The integrase is the enzyme that helps the binding of viral DNA material with the host DNA material. That is inhibited by reltagavir, eltivegavir, and dolutegavir. Reltigavir, at least remember this, reltigavir is a integrase inhibitor. There is a confusion because when there is a MCQ, fusion inhibitor and integrase inhibitor. Fusion inhibitor, they inhibit the entry. Integrase, integration of two DNA component or double stranded component, viral and host, that is inhibited by reltagavir. Whereas fusion inhibitor is enfuratide. Enfuratide is the fusion inhibitor. They inhibit penetration of this virus. Another penetration inhibiting is CCR5 co-receptor inhibitor, that is maraviroc, whereas enfuratide is a fusion inhibitor. Integrase inhibitor, they inhibit integration of viral component with the host DNA, that is relticavir. Clear? The last one is protease inhibitor. Protease is an enzyme which helps to assembles this viral component which is already synthesized by protein degeneration, and that is called protease inhibitor. Protease inhibitor, namely indinavir, nelfinavir, ritonavir, lopinavir. So it also end with vir. The important thing for MCQ purpose, so abacavir is the abacavir, though it is end with the VIR, it is a nucleoside reverse transcriptase inhibitor. Most of the VIR is complete protease inhibitor. Some of them are integrase inhibitor, but abacavir is the only non-nucleoside reverse transcriptase inhibitor which ends with VIR. So for MCQ purpose, you have to remember this: abacavir is a non-nucleoside, a nucleoside reverse transcriptase inhibitor. It is not a protease inhibitor or integrase inhibitor. Another confusion is fusion inhibitor with integrase inhibitor. Fusion inhibitor is enfuratide. Another entry inhibitor, that is CCR5 co-receptor inhibitor, that is maraviroc, and integrase inhibitor is relticavir. Other than that, two more important is reverse transcriptase inhibitor and protease inhibitor. These are primarily the reverse transcriptase inhibitor is the first line drug. Second line drug or add-on is protease inhibitor, and rest of this, that means integrase or fusion or CCR5 inhibitors, these are some of reserve drug, very rarely used as a first line drug. Okay, so first line drugs are NS nucleoside reverse transcriptase inhibitor with one nucleotide reverse transcriptase inhibitor. Three drugs, two from the NSRTI and one from the NNRTI. Clear up to this classification of antiretroviral drugs. You can go for the like this or directly write down. This helps to remember that there is a fusion inhibitor, there is a CCR5 co-receptor inhibitor, nucleoside reverse transcriptase inhibitor, nucleotide reverse transcriptase inhibitor. Nucleotide reverse transcriptase inhibitor is tenofovir. Then non-nucleoside reverse transcriptase inhibitors, efavirenz, nevirapine. Then integrase inhibitor, relticavir. Then protease inhibitors like sacubitril, indinavir, nelfinavir, ritonavir. Abacavir, though the end is VIR, it is a nucleoside reverse transcriptase inhibitor. So nucleoside reverse transcriptase inhibitors, zidovudine, diadenosine, it is a nucleoside and nucleotides analogs. Mechanism of action, how they are, just name. Mechanism of action, it is a selective reverse transcriptase inhibitor. Selective reverse transcriptase, that enzyme inhibitor. Most of this time it is a competitive antagonism. Competitive antagonism, what is that? Competitive antagonism, what is non-competitive? Structurally similar. With increasing dose, we can overcome the higher effectivity. So it is a competitive inhibitor. In NNRTI, non-nucleoside is a non-competitive one. NSRTI, NTRTI, nucleoside and nucleotide reverse transcriptase inhibitor, it is a competitive. How? And they inhibit, they incorporate itself to the growing DNA and that helps to terminate. So mechanism of action of nucleoside reverse transcriptase or nucleotide, they inhibit reverse transcriptase enzyme competitively, they incorporate itself in the DNA and terminates their DNA chain elongation. Mechanism of action of nucleoside and nucleotide reverse transcriptase inhibitors. Zidovudin, orally effective, they can also penetrate the CSF and primarily excreted through the kidney. Pharmacokinetic, orally taken, penetrate the CSF and excreted through the kidney. Side effect, bone marrow depression. What other drugs has a bone marrow depression side effect? Name some other drugs. Okay. Then headache, nausea, anorexia, myopathy and fatigue. Low dose can be used in children. It can be also used during the pregnancy as well as during the delivery and after delivery, postpartum period. So children, pregnancy, postpartum period, this drug can be used, that is zidovudin. Side effect is, one side effect, it will be remembered, bone marrow depression. There is also, but encetavine is not used in pregnant. If the patient, AIDS patient is pregnant, we cannot be used that. We use primarily zidovudin. Orally highly absorbed, not affected by food, GI absent, and important for MCQ purpose, hyperpigmentation of sole as well as palm. Hyperpigmentation of palm and sole is important side effect of it. Diadenosine, bioavailability reduced by the food, eliminated by the kidney, important for MCQ purpose, can cause acute pancreatitis. So patient receiving diadenosine, if the upper abdomen severe pain which is relieved by sitting up, we have to investigate for amylase lipase. There may be high amylase lipase that may be due to drug-induced pancreatitis due to the diadenosine. Other than, it is the most important side effect. Other than that, retinal damage and peripheral neuropathy. Retinal damage and peripheral neuropathy are among the other side effects of diadenosine. Next is therapeutic effect. They increase, all these are non-nucleoside, nucleoside and nucleotide. They increase T cell and that helps to restoring the immune system. They can also reverse the AIDS-induced dementia. AIDS-induced dementia can be reversed by nucleoside and nucleotide reverse transcriptase inhibitors. But primarily, they increase the, develop the immune system by increasing the T cell. T cell count will be less if HIV infection progresses. This drug helps to increase T cell, they helps to develop or increase the immune defense. Non-nucleoside reverse transcriptase inhibitors, nevirapine, entradavine, nevirapine, you have to remember at least nevirapine. Mechanism of action of nevirapine, they bind near the site of viral reverse transcriptase to inhibit their activity, not in the site. Receptor competitive and non-competitive কিভাবে হয় যে এক্স্যাক্টলি সেই সাইটের জন্য যদি দুটো একটা ড্রাগ আর সাবস্টেন্স কম্পিট করে, that is competitive. But if they binds in the same receptor but different site, by binding the different site of the same receptor and conformational changes, then there will be non-competitive type. So non-competitive inhibitors of the reverse transcriptase enzyme is non-nucleoside reverse transcriptase inhibitors. Pharmacokinetic commonly orally taken, metabolized in the liver, excreted through the urine. These are the inducer of P450 enzyme cytochrome of the liver. Now tell me, if these drugs given with a substance, what will be? There will be a therapeutic failure or there will be a toxicity? Huh? There will be failure because they increase the metabolism of this other drug. Very effective to prevention of transmission of the infection. As a single dose at a time of labor and continue oral dose of 3 days of the neonates. Clear? So, when there is a pregnancy patient infected with HIV, this drug given a single dose during the delivery, and there will be continuation of 3 days for the neonate, and they prevent the mother to child transmission. Mother to child HIV transmission will be reduced. Side effect, hepatotoxicity. Nevirapine has a very serious side effect, SGS, Stevens-Johnson syndrome, SGS syndrome. That can be a life-threatening one also. Nevirapine has a side effect of that. Then diarrhea, headache. So, for diadenosine, side effects are diadenosine, pancreatitis, retinal damage, peripheral neuropathy. For Zidovudine, bone marrow depression. Nevirapine, for nevirapine, it is SGS, Stevens-Johnson. Next is protease inhibitor. Protease inhibitor are ritonavir, azithromycin. How they act, mechanism of action, they block an enzyme called protease, as the name suggested, that produce the maturity of the virion. The protease enzyme which helps to mature the virions, that is blocked by the protease inhibitor. These protease enzyme helps to polyprotein cleavage. Maturity, how its maturity occurs, the polyprotein cleavage, and that will be prevented by the protease inhibitor, which is necessary for this maturation. Clear? So, maturation of virions is inhibited by the protease enzyme inhibitors. Protease inhibitor, they help to polyprotein cleavage, which is important for the maturity of the virions. Pharmacokinetic, oral absorption, but for oral absorption, they require acidic environment. Eliminate through the bile, not through the kidney. Okay. Most of these drugs primarily before these are excreted through the kidney, but this is excreted through the bile. This is the enzyme inhibitor of P450. Previously, NNRTI is inducer. The inhibitor কি করে? Toxicity না? Toxicity করে, failure করে না. Ritonavir is one of few drugs which absorb better when taken with the food. Can you name other drugs? Huh? Thiopentazone, albendazole, okay. Another drug, more important, graciofulvin. It is an antifungal. When it takes with the fatty food, it absorbs better. Most of the time, drugs absorption is prevented or reduced by the food. There are few examples like ritonavir, like graciofulvin. If they take with the food, their absorption is better. Clearance is mainly through the liver. It is also an enzyme inhibitor for P450. The protease inhibitors are the inhibitors of P450, whereas NNRTIs are inducer of P450. Side effects: increased bleeding time, especially in the hemophilic patient, increased blood sugar level, may precipitate diabetes or worsen diabetes, changes of body fat distribution, central obesity, buffalo hump, gynecomastia. Is there any other drug that can cause this type of symptom? Buffalo hump, steroids. Steroids can also cause central obesity, buffalo hump. The increase in blood sugar, protease inhibitor, side effect of protease inhibitor, increase of sugar, increase of bleeding tendency, redistribution of fat, buffalo hump, central obesity, somewhat similar to the chronic steroid use. This is the buffalo hump. Entry inhibitor, Maraviroc inhibit CCR5. That is a co-receptor. Co-receptor, they inhibit that. But if the virus bind with the chemokine 4 receptor by binding chemokine receptor type 4, not CCR5, then Maraviroc is not a good drug. It cannot prevent that. Entry inhibitors. They can cross the CSF, excreted through the feces, and well tolerated and fewer side effects. Even then, this drug is not the first line drug. Why? Because you don't know the HIV binds with the CCR5 co-receptors or cytokine chemokine type 4 receptors. Clear? There may be early development of resistance. So this is not the first, it is only a reserved drug. Okay, now only we come to the what we have to write down or know about the HAART. Up to this classification of antiretroviral drugs. Now we start our topic is HAART. HAART full form is Highly Effective Antiretroviral Therapy. Currently, NACO gives the priority treatment to all HIV patients who has a stage 3 and stage 4, mean later stage. Number 2, if HIV positivity at least for 6 to 8 years. Then if the patient, HIV patient having concomitant infection of TB or herpes, HIV patient, pediatric HIV patient less than 15 years, if HIV partner of an AIDS patient. HIV and AIDS is not a similar thing. AIDS means full form of AIDS. So that is the later stage. Not all HIV patient goes into the AIDS, but all AIDS patient must be infected by HIV. So these are the primary criteria to start the antiretroviral therapy. Stage 3, stage 4, 6 to 8 years, pediatric age group, concomitant infection of tuberculosis, pulmonary tuberculosis and herpes, and HIV with a AIDS partner, HIV infected patient with a AIDS partner. So these are the criteria of start highly effective antiretroviral therapy. So just to remember, if the stage 1, stage 2 patient having CD4 count less than 350 or some book refer it as a 400, then we have to start. For stage 3 and stage 4, it is irrelevant to measure the CD4 count for initiation of therapy. Clear? 1 and 2 we can start a HAART when CD4 count is less. But in 3 or 4, irrespective of the CD4 count, we have to start HAART. Similarly, if HIV patient co-infection with the HBV or HCV, hepatitis B or C virus, without any documented chronic liver disease, LFT is not deranged or we doesn't have a report of LFT, then we have to start if only CD4 count is less than 350 or 400. But if there is a evidence of severe, chronic severe, then irrespective of the CD4 count, we have to start HAART. So basic thing is that if their symptoms is there, then we can start, then we will start. If symptoms is not there, evidence is not there, then we go for the CD4 count. CD4 count is less than 300, 350 or 400. Irrespective of the symptoms, we have to start a HAART. Clear? Next, now there is a trend towards the HAART guideline 10, 13 and nowadays all gives a, previously we always, all these drugs have a very severe side effects. Clear? So we have to balance the side effect and effectiveness. Is it required, or due to the side effect patient become ill? But towards now we shifted towards the, even there is a side effect, we should start HAART early, antiretroviral therapy early to survive the patient. All this HIV plus asymptomatic, symptomatic, pregnant, breastfeeding, TB, HIV, HBV, co-infection partner, all gives that indication towards the trend towards the early start of highly effective antiretroviral therapy nowadays. Previously we have to conservative. The side effect is there, effectiveness is there, we have to check the balance. More nowadays trend goes towards starting the antiretroviral therapy early. Regime, there is at least 3 antiretroviral drugs, at least 3, and it should become at least from 2 classes. 3 drug, 2 class at least. There may be 3 class, but not from the same class. 3 drug from non-nucleoside reverse transcriptase inhibitor not effective, less effective. At least 3 drug, 2 subclass. Treatment of naive patient therapy is optimal if we start with 3 drugs. Naive means the first time diagnosed, there are no exposure of any other antiretroviral drug. Newer patient is effective, optimal. And our target, what is our target? Our target is reduce HIV RNA. HIV RNA up to less than 50 copy per microliter, that is undetectable. There are two measures will be there. One is viral RNA, one is CD4 count. So the primary one is viral RNA, not CD4 count. If the viral RNA will reduce, concurrently CD4 count will be increases. Clear? So CD4 count less than 50 copy per microliter within 6 months. If after 6 months we see that the copy is more than 50 or detectable, that means there is a failure of the therapy. We have to either change the therapy or increase the therapy. Clear? So our target is less than 50 copy per microliter within 6 months. It may be within 1 month or within 5 months or 5 months, 21, within 6 months, not beyond the 6 months. First line regime primarily have 2 NRTIs and plus 1 NNRTIs. The 2 class 3 drug. 2 class 3 drugs. Tolerability and efficacy is important. Tolerate korte parche kina patient, and efficacy. Effectiveness of the drug is more important than the cost. Cost is very high. So we cannot compromise efficacy or tolerability to reduce the cost. So more important thing is effectiveness of the drug, and tolerability by the patient is more important than the cost. Principles are all regimes 2 NRTI plus 1 NRTI, include lamivudine. Try to include lamivudine if there is no resistance in all regimes. Other NRTIs are zidovudine or stavudine. Choose one NRTI, efavirenz or nevirapine. Efavirenz or nevirapine. Efavirenz, they cause hepatic dysfunction and concurrently, when used concurrently with rifampicin. Why it is important? Because these AIDS patients, they are maybe co-infected with pulmonary tuberculosis. In that situation, as we have to give rifampicin, we prefer then nevirapine, efavirenz for that. Do not use efavirenz in pregnant. Tuberculosis থাকলে efavirenz prefer, pregnancy থাকলে nevirapine prefer. Single class regime is inferior. Why we doesn't prefer PI as a first line? Because more convenient and low pill burden when we give this 2 NRTI and 1 NRTI, simpler dosing, more acceptable, better tolerable, less metabolic complication. Metabolic complication with PIs are much high, but it can use when first liner failed. To reduce, our target is less than 50 copy of viral RNA after 6 months. Preferred over higher low dose ritonavir boosted the PI. It preferred over the higher single dose PI. So if there is a failure, no dose reduction, if there is a side effect, there should not be no drug holiday. So no dose reduction, no drug holiday is recommended. Treatment is lifelong. So if there is a failure, if there is a intolerable side effect, we have to change the regime totally rather than reduce the dose or drug holiday. There is another thing that the name is immune reconstitution syndrome. Immune reconstitution. When we give this antiretroviral therapy, suddenly immunity of the patient develops. CD4 count increase. And as the immunity develops, there may be some symptoms increases, the inflammatory changes against the residual organism. But we shouldn't reduce or change that regime at that time, because it is due to the betterment of immunity, these types of inflammation is there. This causes immune reconstitution syndrome. If there is a symptoms is there, CD4 count is increases, that means it is a good sign. So in this situation, to treat the inflammation, we give steroids. Instead of reducing dose, changing the regime or drug holiday, we only give the steroid to control the inflammation rather than the other way around. It is a better immune system, so they develop inflammation against the organism. Pregnancy in women doesn't contraindicated with antiretroviral therapy. In pregnancy also we have to give antiretroviral therapy, not only to treat the mother but also to prevent the transmission to the children. We have to give that. Drug relatively safe during the pregnancy is zidovudine, lamivudine, nevirapine, nelfinavir, saquinavir. Should not be discontinue any ART due to the opportunistic infection. Opportunistic infections means pulmonary tuberculosis, herpes zoster, this type of, except if there is a intolerance of the drug or there is a toxicity. National regime 1 হচ্ছে zidovudine, lamivudine, nevirapine if hemoglobin is more than 9. If less than 9, tenofovir instead of zidovudine. Similarly, regime 2 Zidovudine, lamivudine, efavirenz, if the patient regime 2 given when the patient having ATD and if there is a rifampicin. Regime 2A instead of zidovudine, tenofovir if hemoglobin is less than 9. That means as zidovudine causes bone marrow depression, we discontinue or not prefer zidovudine if hemoglobin is less than 9. Clearly, efavirenz preferred when there is a ATD is there. Antitubercular drug containing rifampicin. Instead of nevirapine, we give efavirenz. Even co-infection with hepatitis B, C, we prefer the regime 2A. Is not required for you. So consider failed. Kokhon amra this regime is failed for this patient. When plasma RNA less than 50 is not achieved after 6 months of intense therapy. Repeated detection of virus in plasma after initial suppression. Clear? Clinical deterioration and fall in CD4 count. Failed regime, আমরা diagnose করলাম. What to do then? We should change it entirely. All 3 drugs should be changed. To avoid overlapping viral resistance. A boost PI nearly always included in second line. And PI is added more commonly in the second line. When there is a repeated failure, we add integrase inhibitor, CCR5 inhibitor and fusion inhibitor. These are reserved for the repeated failure. Clear? Post-exposure prophylaxis and pre-exposure. Post-exposure means if there is a needle prick and you got to know this patient having HIV infection in there. So, when to start? As early as possible within 1 to 2 hours, but it may started after even 2 weeks. Nevirapine is not indicated for prophylaxis, post-exposure prophylaxis due to the hepatotoxicity. Include at least 2 drugs that source means the patient having the HIV is not receiving. These are the post-exposure prophylaxis primarily. If there is a low risk, zidovudine and lamivudine twice daily for 4 weeks. And if there is a high risk, that means risk kibabe hobe? The small needle, larger needle, spillage of the drug, viral load of the patient. Depending upon that, zidovudine, lamivudine, indanavir in case of high risk. Clear? Low risk ke jonno zidovudine and lamivudine, add on indanavir for the high risk. Pre-exposure and post-exposure. Pre-exposure means if a healthcare regularly working in such a situation when there is a repeated chances of needle prick or exposure, then sometimes it started even before the exposure. But mostly in our setup, we use post-exposure. Though it has been seen that it is effective, more effective, but cost effectiveness, side effect, in our situation, we prefer post-exposure prophylaxis. Clear? তাহলে classification of antiretroviral drugs and HAART. এই দুটো কিন্তু very very important for semester as well as for final. HAART এ কি লিখতে হবে, কখন স্টার্ট করতে হবে, কি ড্রাগ দিতে হবে, আবার টার্গেট কি হবে, যদি ফেলিওর হয় তাহলে কি করতে হবে, আর যদি ইমিউন রেসপন্স কম হয়, বেশি বাড়ে যখন, তখন আইরিস হতে পারে, রিকনস্টিটিউশন সিনড্রোম, তখন আমরা কি করব। ঠিক আছে, তো দুটো জিনিস, একটা হচ্ছে ক্লাসিফিকেশন অফ দ্য ড্রাগ অ্যান্ড হচ্ছে হার্ট, এই দুটো পড়লে মোটামুটি এইচআইভি কভার হয়ে যাবে। আর ছোট করে একটুখানি ওই পড়ে রাখতে হবে পোস্ট এক্সপোজার প্রোফাইল্যাক্সিস, ঠিক আছে।